Welcome all, and it's a pleasure to be with you for the continuation of the Houston Methodist Multi-Modality Imaging Conference. And for everyone joining us today, there'll be the opportunity to ask questions. For those joining by the web, please go to pollev.com and enter DeBakey to enter your questions. For those joining wanting to ask questions by text, please text DeBakey to 37607 to send in your questions. And today I'll be taking us through an introduction to the peripheral vasculature, and this is going to be a pretty dense talk, so please bear with me. There's a lot of slides to cover. These are just my disclosures. And a brief word about the Registered Physician in Vascular Interpretation. This is a vascular interpretation certification that's offered by the Alliance for Physician Certification and Advancement. This is now a requirement for the vascular surgery training as of 2014. It's actually expected as several vascular medicine fellowships as well. So what will I be discussing? I'll be covering a broad overview of common peripheral vascular diseases. I also do a brief review of imaging criteria and classification of such entities. I'll also be going over the imaging modalities for diagnosis and assessment of these entities. What I won't be discussing is entities previously discussed under aortic multimodality imaging. Doctors Mohammed Chamsi Pasha and Miguel Quinones covered that in great depth, although I will be highlighting some physiologic aspects related to the aorta affecting peripheral vasculature. I will not be covering a review of acute or chronic medical management and supporting literature for these different entities. There's a reason why there's an entire vascular medicine subspecialty nowadays, and before that, a whole vascular surgery department that deals with these matters. And I will not be covering a review of procedural or surgical management options and surveillance and supporting literatures. So when it comes to vascular imaging and diagnosis, this is really truly a multimodality endeavor. This requires the collaboration of the vascular laboratories, MRIs for doing MR angiography, CT with its angiography, and also the ability to do PET scans and nuclear imaging, as well as, of course, fluoroscopic angiography, where both diagnostic angiographies and interventions may take place. There are different vascular beds involved, and this is a rough breakdown of the different beds that are commonly examined. I'll be covering the cerebral arteries, both extracranial and intracranial vessels briefly, as well as the extremities, and broken down into arterial and venous diseases. I'll briefly cover abdominal and pelvis angiographic assessment, and also briefly mention lymphatics as well. There is an entire appropriate use criteria established by the ACC, AHA, and different vascular professional organizations, and I encourage everyone, if they have time, to go over these themselves. So moving on, beginning with the cerebral arteries. Cerebral arteries begin with the aortic arch vessels, and of that there are many variations that are available. And that are common, and shown here are four that we commonly see in the MRI and CT laboratories. Shown where my mouse is moving is the normal aortic arch, where you have a right innominate vessel taking off to provide the right common carotid and the right subclavian artery, as well as the left common carotid and left subclavian. You can actually see the left vertebral in this case. A very common variant that's brought up is the so-called bovine arch, but it's a misnomer because a true bovine arch actually has everything coming off of a common trunk. In this case, the left common carotid is sharing a common trunk with the right innominate. But there are other common variants we see in the imaging lab. We often see the left vertebral arising directly off the aortic arch, and then there's the phenomenon of what's called arterial lusoria, or the an aberrant right subclavian artery looping just around either the esophagus or around the trachea, depending on its course, before heading to the right arm. There's also another nomenclature used for aortic arch classifications, and this pertains more to those who pursue endovascular approaches in the carotids and subclavians. This refers to type 1, type 2, and type 3. And is discussing really the landing zone of the right innominate artery relative to the greater curvature and lesser curvature of the arch. Depending on how steep this the arch vessel is taking off relative to the curvature, this will then make it more and more difficult for interventionalists to land their wires to conduct carotid interventions. When it comes to the internal carotid artery, this obviously goes on to feed the brain and form the circle of Willis, and this has great significance for those of our in the neurology world, our neurovascular colleagues. There's an entire classification system describing the carotid segments as it advances through the different skulls, and of course the entire circle of Willis that can actually be imaged using transcranial Doppler. Our very own Dr. Zolk Garami introduced this to our vascular lab and has taught many of our sonographers to perform this, and this is commonly used in carotid interventions and cardiothoracic interventions at our center for monitoring brain circulation. When it comes to carotids, there are the usual suspects. No talk is, obviously when we're talking about carotids, the biggest elephant in the room is with strokes, particularly ischemic strokes. This is often due to large artery atherosclerosis, as well as the phenomenon of cardioembolism with atrial fibrillation and cardioembolic sources. But other possibilities can exist that can cause stroke. Again, our neurovascular colleagues are very intimately familiar with these, such as small vessel occlusion, other etiologies like moya, etc. And then there's undetermined etiology where source is never quite figured out. But there's also hemorrhagic and transient ischemic attacks, and those, of course, we turn to our neurology colleagues for assistance in managing. No talk about ischemic strokes and carotid disease is complete without talking about atherosclerosis. There is an entire AHA classification scheme discussing the progression of plaque disease starting from birth when fatty streaks and intimal thickening begin happening, all the way through formation of unstable soft fatty fibroatheromas and the so-called fabled vulnerable plaques that can then rupture and cause an acute event, like an acute stroke or acute coronary event. Of course, then there are other changes to the plaques that can happen, such as healing of the erosion, healing of the rupture. You can also have transformation of the plaque, often seen with lipid-lowering therapies, especially statins, transformation to calcified so-called stable plaques. One thing to keep in mind, though, is that these images are misleading. What usually happens is that there's positive eccentric remodeling first with preservation of the luminal diameter prior to the vessel beginning to narrow in more chronic disease as opposed to an acute rupture event. When it comes to imaging the carotids with ultrasound, there are set guidelines available about that. Obviously, in a patient who we suspect on physical exam with a BRUI, that's an indication for going ahead and pursuing a carotid duplex ultrasound imaging. Any patient who has significant stenosis, and by that I mean anything greater than 50%, regardless of whether or not they're symptomatic, deserves periodic surveillance. And then patients who have multiple risk factors, people may not be aware, but patients who have multiple risk factors for atherosclerosis who are at high risk may deserve a carotid screen as well. Patients with coronary disease or peripheral artery disease fall under that spectrum, and if there's a high suspicion for stroke risk, that should also prompt further evaluation of the carotids as well. And then, of course, patients who are undergoing potential coronary ongoing evaluation for heart surgery that may require cardiopulmonary bypass, these patients usually get a carotid screen to make sure there's no significant disease that may get provoked when the patient's in a low perfusion state. There's more recent guidelines from the European Society of Cardiology, which pretty much reiterate a lot of the same things that I just mentioned. But regardless, one thing to keep in mind, they explicitly state here in lines with what we do at our institution, ultrasound is first, just like echo is first, is a gateway modality to a lot of assessment in the heart. Ultrasound is usually first line for assessing the carotids. But imaging of the carotids actually began early in the disease course. I mentioned that intimal thickening happens, and Dr. Pignoli et al. Established this back in 1986 with cadavers and then in living volunteers, that they were able to see a bright reflective surface and parallel lines indicating the intimal medial layer. And that's actually been formalized in the atherosclerosis risk and community study in their visits. And IMT has been shown not only in the ERIC study, but also in multiple other epidemiologic cohorts to be predictive of future cardiovascular events. This was actually shown in a meta-analysis done by Dr. Lorenz, showing that depending on which quintile of carotid IMT you have, this was predictive of increasing risk of cardiovascular events. But more to the point, even if it doesn't cause stenosis, if you do have a significant plaque buildup, that actually is predictive of future stroke risk and cardiovascular events as well. My mentor, Dr. Vijay Nabi, did this work with the ERIC study and showed that the very presence of plaque on a carotid ultrasound was predictive of future events. There are formal criteria that for defining what a plaque is, usually at least 1.5 millimeters in thickness or greater than 50% increased thickness compared with the surrounding thickness, and this is established in the Mannheim consensus by our European colleagues. But in addition to commenting whether or not the plaques are present, luminal irregularities, and in the nature of the plaque, whether or not it's hyper or hypoechoic. Hypoechoic points more towards a soft fatty plaque, whereas hyperechoic reflects more of a calcified plaque that is bouncing off the ultrasound beams versus a heterogeneous echoic plaque. Now, one problem with ultrasound is a lot of ultrasound is based on 2D technologies and 2D scan plane imaging, and that is shown very clearly on this diagram here. If one is not careful and doesn't do proper sweeps through the long axis of the vessel, they could miss an eccentric plaque that could be looking around. That's why most protocols, including the one at our vascular image laboratory here, includes a short axis, a transverse sweep through the carotids up and down through the vessel to make sure we're not missing plaque disease. I mentioned before my mentor Vijay showing before that in the ERIC study that this was predictive of future cardiovascular events. In his study, it was MI and coronary heart disease death. But then other cohorts have also shown that plaque disease as well is predictive of future cardiovascular events. Going beyond just simply characterizing plaques based on ultrasound, the other modalities are very much aware of this as well. In fact, CT has pursued not only carotid plaque characterization. I understand there's been work done by different groups. I know Dr. Budoff has done work on the cardiac CT side of looking at of coronary plaque assessment and association with future risk. But CT is very much capable of looking at plaque morphology and commenting on the very nature of the plaque composition as well. MRI is, of course, considered one of the gold standards for looking at the different carotid plaque composition. It's a go-to modality for doing tissue characterization in general. And shown here are different examples, is carotid plaque with different features indicating increased fat content and as well as some areas of calcification based on darkened signals inside as well. This actually evolved to the point where there was a group in University of Washington that established the VP Diagnostic Company that we briefly worked with in both Methodist and Baylor for a time. Looking at carotid plaque composition and trying to come out with an automated way of trying to assess plaque characteristics using MRI. But structure and morphology is one thing. active inflammation is quite another, and nuclear and PET modalities are far superior at looking at hot plaques, so-called hot plaques with active inflammation, active macrophage infiltration. And I'm aware that Dr. Moaz Amala is pursuing research to that end at our institution. Shown here is in panel A is a CT, and in panel C, a PET scan showing metabolic activity on FDG PET, and then B is a fusion imaging showing that very clearly that you can see plaque buildup in the carotid vessel. That's I should say plaque buildup, but active inflammation in the plaque, indicating active hot plaque modality, hot plaque on the PET scan as well. Now, what about if the disease has progressed to a point where now stenosis has developed? Well, first let's talk about assessing stenosis. And in terms of assessing carotid stenosis, the NASCET method has kind of won out. And with the NASCET criteria, what's typically done is that the narrowest diameter of the stenosis is measured diameter-wise. The distal vessel is measured as a reference, and then the difference between the two over the distal vessel is used to quantify the percent stenosis. And this becomes significant because depending on what level of percent stenosis we see, that leads to possible interventions. And then, of course, it depends on whether the patient has symptoms. There was a nice JAMA article done, I'm sorry, not a JAMA article, but survey done, I should say, of different big trials, like the NASCET trial and the ECST trial and the VA trial, as well as the ACAS trial, an ACE trial, that looked at number needed to treat in terms of endarterectomy in symptomatic patients versus and percent carotid stenosis versus those who are asymptomatic. And as you can see, once patients are symptomatic, the number needed to treat goes down considerably. So patients who are symptomatic, who have over 50% lesion, there is a recommendation to refer to our vascular colleagues to consider endarterectomy. Less than 50% becomes more questionable in the literature. And then for asymptomatic patients, those who have over 60% lesions, the number needed to treat is much greater. And so that's why it becomes an active area of a debate as to whether or not to intervene in these patients. So I threw around 50% and 70% in stenosis and all that, but does it for clinical implications as to whether or not they would benefit from endarterectomy intervention. But what does it mean physiologically? Well, it turns out Dr. Spencer and al. Did the seminal work back in the 1970s, showing that once you cross the 70% stenosis, that there's a rapid drop-off in blood flow. That's shown in this diagram here. This is luminal diameter, and as the luminal diameter goes smaller and smaller from the right hand of the screen to the left hand of the screen, once you cross 70%, there's a rapid drop-off. Anywhere between 50% and 70% is debatable, and that's why the entire arena of FFR, et cetera, then came into being to try to tease apart whether or not there's hemodynamic significance to a so-called moderate stenosis. But other things to keep in mind is that the systolic velocity actually starts increasing as well until it hits a certain point with the stenosis and then gradually begins tapering off. What's not shown here is that there's actually a change in diastolic flow velocities as well. It starts gradually going up and up until it's pretty sustained, because then there's post-stenotic vasodilation that then tries to compensate for the decreased blood supply to the organs on the receiving organs on the other end. This is showing on the right hand of the screen is the difference between asymmetric versus axisymmetric or concentric stenosis, and whereas asymmetric stenosis tends to follow more a linear relationship between cross-sectional area and diameter, and thus be a little more predictable in terms of stenosis. Asymmetric concentric stenosis tends to be a little more parabolic in nature. Okay. Now, when it comes to ultrasound, Eugene Stradnis at the University of Washington came up with the initial guidelines discussing peak systolic velocities and spectral characteristics. And the more seasoned vascular imagers, vascular ultrasound techs, are aware of these spectral characteristics that can be changed with increasing stenosis. So as you can see, there's more spectral broadening, kind of noisiness, if you will, in the Doppler, spectral Doppler envelope that begins to gradually occur with the Doppler spectral characteristics. The velocity 125 was the cutoff that Eugene Stradnis used, and that's still used in the revision. Then I'll move on to the next slide. But this is the actual consensus, Society of Radiologists in ultrasound consensus that was published initially in 2003 that integrates not only the peak systolic velocity, but also introduces the concept of ratios. So nowadays we take the peak velocity that is measured in the internal carotid, and take the peak systolic velocity measured in the common carotid artery and come up with a ratio of the two, the ICA to the CCA. And if it's above 2, then that points more to a significant stenosis, meaning over 50%. And if it's above 4, then it's decidedly more suggestive of a greater 70% occlusion. Peak systolic velocity follows suit, although it may be blunted at near or total occlusion states. But as you can see, the diastolic velocity starts ramping up in the ICA, as I mentioned before, because of the post-stenotic dilatation to compensate. Okay. There are certain issues with trying to image on ultrasound, though, because when you point the probe down, you're seeing a cross-sectional 2D image. You may not know what you're looking at, and that's why the transverse sweep is usually helpful to try to help differentiate. But then once you get to the branch point, trying to figure out what the difference is between the internal carotid versus external carotid artery is. There are some helpful clues, like the internal carotid artery tends to be larger, it tends not to have branch points. It says here lateral and posterior, but patients don't read the textbook. The ICA and ECA can have different orientations relative to each other in the neck, especially in older folks where the vessels are more tortuous. Internal carotids tend to have lower resistance, and usually if you do what's called a temporal tap, you should not see the tapping on the internal carotid, whereas you will see it on the external carotid artery. Okay. So I mentioned before, peak systolic velocity gets increased in more severe stenosis can be suggestive of significant stenosis, but near and total occlusions can result in blunting. And shown here is an example where you don't see the ICA. You see all these branch vessels that indicate on this angiogram the external carotid, but the internal is this near this small thread. Here are shown the Doppler, the B-mode ultrasound with a color mode Doppler superimposed that show that there's also trickle. And you can see here the spectral Doppler, the peak systolic velocity is only 8 centimeters per second, as opposed to the higher velocities that's typically seen with regular vessels and more significant stenosis. So when we're imaging the carotids, we also take one more additional step and also take a look at the vertebral arteries and subclavian arteries as well. So we also do this because in CABG patients, the lima, the IM and REMA tend to take off from the subclavian arteries, and so it's helpful to make sure there's no underlying subclavian disease. Because if a heart surgeon goes and does a lima bypass and misses a significant subclavian stenosis, then the patient's going to have residual coronary disease and angina because of the subclavian disease. So what's typically found is that on physical exam, there's usually a 10 to 20 millimeter blood pressure difference, and there's corresponding arm fatigue. There may be vertebral steal because the arm not able to get circulation from the subclavian artery will then reverse the antegrade flow into retrograde flow into the vertebral artery. And so And so ultrasound will try to pick that up, but CT and MRI will then provide a better imaging because unfortunately ultrasound doesn't get around bone very well, and the vertebral arteries obviously pass through the spinal through the foramina and the spinal vertebral bones. There are clues, though, that on ultrasound can be used to determine whether or not there's a vertebral stenosis, and there's actually a classification system referring to the change in the vertebral spectral waveform in terms of systolic blunting. As we go from type 1 to type 4, you can see there's more and more progressive systolic blunting of the spectral waveform into vertebral artery. I mentioned transcranial Doppler, and as I mentioned, Dr. Garami has established that at our center for a lot of different purposes in stroke patients and in patients getting heart and vascular procedures for monitoring brain status. And usually what's done is a very, very high energy, low frequency ultrasound probe is placed at different windows around the skull. There's periorbital where the energy is actually turned down, so you don't want to cook the eyeball after all, trying to get to the anterior circulation of the brain. And then use higher energies to overcome the temporal skull window and the suboccipital region as well. Those are different entry points for the ultrasound, for the Doppler ultrasound beam. And what's projected, these are images shared by Dr. Garami with me, are the colored Doppler through the different vessel segments. You can kind of sample through this using a line, the corresponding spectral Doppler at the different points, and figure out where you are, whether or not you're in the anterior communicating artery, whether or not you're in the middle cerebral artery, whether or not you're in the branch points in the basilar artery, etc. All that is possible using transcranial Dopplers. So that's with carotid stenosis, with atherosclerotic disease, and trying to figure out risk and once a stroke develops, subsequent circulatory issues related to a stroke. But those are the common usual suspects. Carotid diseases also have unusual suspects, and shown here is a laundry list of different ones, but I'll briefly touch base on a couple of them that we sometimes see. That fibromuscular dysplasia, vascular inflammation, arteritis syndromes. There's tortuosity that I mentioned that shows up more and more in older people. Connective tissue diseases and aneurysms. Pseudoaneurysms and blowout syndromes are very, very rare. But those are obviously a medical concern because of the possible cerebral compromise. Carotid dissections can be detected. Carotid body tumors like paragangliomas can also be detected. There's idiopathic carotid dynia, and there's of course eagle or stylohyoid syndrome, where one of the bones in the skull and neck can actually cause impingement on the carotid artery as well. This is what tortuosity looks like on the carotids, and actually, this is actually a favorite question on any kind of ultrasound physics question. So it can show up in echo boards or vascular certification exams. But since it switches whichever way, depending on how the blood is flowing towards or away from the Doppler probe. This is often comes up in terms of making sure you understand how blood flow shows up on a color Doppler image. This is a power. I'm sorry, not a power, but this is a color Doppler of a carotid artery, showing that there's a separation of the color due to a intimal flap from a carotid dissection. So when this is seen, the next stage is to immediately try to get this patient some kind of CT image of their chest, because you want to make sure this isn't some kind of aortic dissection that's extended up into the arch and into the neck vessels. So if you see a dissection, that should prompt some move towards emergent diagnostics in such a patient. There's fibromuscular dysplasia, and this tends to commonly involve the internal carotid and renal arteries, although less commonly the visceral and extremities. But when it shows up, the classic description is kind of a string of beads appearance. That's very suggestive on different imaging modalities. So if you do see string of beads kind of pattern, that should prompt a workup for fibromuscular dysplasia in these patients and look at other vascular beds that might be affected. This is actually divided depending on which part of the intimate media layer is affected, and medial fibroplasia is the most common and hence causes the string of beads appearance. Although type 2 involving the intima only and type 3 involving only one wall, but having diverticular and web-like septum can also develop as well. I mentioned carotid body tumors or perigangliomas. When a vascular tech plumps the ultrasound probe on the neck, they'll see kind of like a constellation with blood flow going all sorts of different directions with the internal carotid and external carotid artery splayed apart because of the carotid body. These are very, very vascular structures. Sometimes they may be active, they may be neuroendocrine type and secreting some kind of neuroendocrine hormone like catecholamines, et cetera. And so once these are seen, further evaluation and referral to the appropriate surgeon to handle this is recommended. So that's the carotid disease in a nutshell. I will move on now to extremities and talk about arterial diseases first. And with that, I like to start off with talking about anatomy first, and let's begin with the upper extremities. So one common entity one common entity. This is an entity that shows up every now and then, and this is the thoracic outlet syndrome. Usually, what happens is these patients, when they move their arm a certain way and turn their head a certain way, they notice their arms feel tired. And so how this is usually diagnosed is having them perform what's called the Adson maneuver, where they lift their arm and turn their head the contralateral direction. And this leads to pinching of the subclavian artery as it exits. And so when this is diagnosed, then there's talk of doing surgeries, either usually taking out a rib or something to try to alleviate that as well. Turns out we can do some kind of vascular testing in terms of endothelial health and atherosclerosis, and there's something called brachial artery reactivity testing, and this is actually a formal setup where they'll purposely occlude the brachial artery and then relax it and measure the change in diameter of the brachial artery. But this requires an ecenter that's very experienced in it, that has the setup that can do it reproducibly. They actually have to have the probe mounted on an arm and keep on a supporting arm that will keep it stable and image this in a volunteer, and so far has been confined mostly to the research perspective. For good measure, if they can't induce vasodilation, they'll actually infuse patients with nitroglycerin or give them nitroglycerin tablets in order to try to induce a vasodilation to see if there's reactivity testing. But poor reactivity testing results indicate poor endothelial function and might be suggestive of microvascular disease. Moving on to lower extremities, and it's usually here that I get into fun debates with my trainees, because it can get confusing when we start talking about the lower extremity arteries, particularly in the calf. So when the artery passes through the leg, turns from the superficial femoral and to the popliteal, and then begins bifurcating into the anterior tibial artery and the tibial peroneal trunk, and the tibial peroneal trunk further bifurcates into a tibial artery and a peroneal, a posterior tibial and a peroneal artery. It gets very confusing fast. So what I usually recommend to people reading is I like to, on MRAs and CTAs, start off by looking at the bone structures. So I look for the tibia and look for the fibula, look for the interosseous membranes, and in this case this is the right, imagine this is we're looking at the right leg, what I look for is the interosseous membrane, because the anterior tibial artery punctures through the interosseous membrane very early on and goes anterior along the interosseous membrane towards the foot. the peroneal artery bifurcates and then moves laterally and tracks on the posterior aspect of the interosseous membrane, following the anterior tibial artery all the way down into the foot as well. And then the posterior tibial artery stays more medial and tracks along down before it hits the ankle, and that's where on physical exam we tend to find the posterior tibial artery when we are doing our physical exam. Bit of trivia, the posterior tibial artery is more specific for picking up PID, so I usually try to make sure I at least identify the posterior tibial artery on physical exam when I'm doing my pulse assessment. When PID does occur, just like with any system in the body, there's the arterial system in the body is very good at forming collaterals, and so when you see PID anywhere in the body, you should begin trying to look for collaterals, be it through the epigastric hypogastric IMA arteries, be it through the geniculate arteries, or around the pelvis, and also through the arches in the hands and feet. Okay. But as an initial screening tool for detecting peripheral artery disease, there's something called the ankle brachial index. And with the ankle brachial index, how that's done is you take the systolic blood pressure in either the dorsal pedal artery or the posterior tibial artery in both ankles, and you also take the brachial systolic blood pressure in either the right or left arm. You take the higher brachial systolic blood pressure in either arm and use that as your reference as a denominator. And then the systolic blood pressure, you take the ratio, and depending on what the ABI you get, that could be suggestive of peripheral artery disease. Shown here is what one article published about the cutoffs, and usually 0.9 is the ratio agreed upon, below which PAD is considered possibly present in a limb in a patient. Whereas ABI is greater than 1.4, there should be concern of calcifications in the vessels commonly seen with diabetics that can impair being able to compress the vessel and thus lead to artificially high ABIs. So keep in mind that if you get an ABI less than 0.9, that's suggestive of possible significant PAD, and over 1.4 should prompt consideration of calcific disease as well. So when this occurs, then the next step is to consider a further assessment, be it through segmental blood pressure or ideally through a runoff, an angiogram, either through CT, MRI, or through fluoroscopy. If the ABI is suggestive, that is recommended in the PAD guidelines published in 2016 through the ACC/AHA for considering further imaging. And I leave this for you for reference. There is the option for segmental blood pressures, and this is either done with Doppler or with pulse volume recordings. These are a bit different. With Doppler recordings, they look at the velocity flow through, so spectral Dopplers through, I shouldn't say spectral Dopplers, but they look at the Doppler signal characteristics through the artery in question. And there's actually a triphasic effect to it. So there's initial systole forward flow, momentary reversal, and diastole, followed by forward flow and further diastole. And I'll explain this phenomenon in a bit. This actually relates to the interplay between the aorta and the peripheral vasculature. There's also pulse volume recordings, and shown on the left hand of the screen is examples of pulse volume recordings. Shown here are Doppler recordings. And you can actually do these measurements through every single leg segment, so the thigh, the upper and lower thigh, the upper and lower calves, and through this method began localizing where the possible occlusion may be occurring. Shown here is a patient with all these blood pressure cuffs slapped on, and this is a great way for for trainees interested in working in the vascular lab to learn how to put on blood pressure cuffs very, very fast. Yes, this setup is actually done in our own vascular lab for doing segmental blood pressures, and we tend to do more Doppler waveforms. I mentioned before that a normal Doppler waveform in the leg should be triphasic, and that's because there's actually a series of pressure waves that occur in the aorta. So what happens when the heartbeat stroke volume is delivered into the aorta? There's momentary propagation of forward pressure waves through the aortic wall, through the entire aortic vasculature. But as it begins hitting more and more vascular resistance, it's kind of like a ball like a tennis ball hitting a solid wall. And so what happens is the pressure wave will then reflect back through the entire aorta and cause a momentary reversal in blood flow through the aorta. This was observed by our interventional colleagues long ago when they had catheters in the aorta measuring pressure waveforms. They would notice there was these dips in blood pressures both in the periphery and in the aorta. And shown at the very top is a young person in their at the age of 19. Shown at the bottom is a patient who was 83, and and in between is a middle-aged person at the age of 42. Shown on the right hand of the screen are aortic tracings, pressure tracings. Shown on the left are radial artery pressure tracings. And as you can see, in a younger person, because there's a delay in the returning pressure wave, there's a delay in the augmented pressure coming back. Some theorize that this actually augments the blood pressure and blood flow back into the coronaries during diastole. And as you can see, as we age and the aorta actually gets stiffer, the pressure waves, the reflected pressure wave actually returns back much faster, and so you actually get more exaggerated pulse pressures in older individuals. And there's a theory that because we lose the diastolic augmentation of retrograde pressure waves, that this may be part of the reason why we see more events, more ischemia, more angina and heart disease in older patients. But this phenomenon actually takes place as well, and we notice this when we're doing peripheral vascular assessment in the extremity arteries. We'll actually see a triphasic waveform indicating momentary blood flow reversal. In patients who have limb ischemia conditions, and then it's less useful to talk about arterial stenosis because there's only so much we can do. There's actually the ability to look at perfusion pressures and oxygen tension using special sensors. And shown here is a device that looks at oxygen tension in the body, and shown here is a patient who has non-healing ulcers related to PAD, and the technology being used to assess oxygen perfusion in his limb. But this is used by the vascular surgeons to determine whether or not there's any hope of salvaging a limb, whether or not there's any hope of having the wounds heal properly. If not, then it might be time to consider more extreme measures such as amputation. Okay. This is a bit busy slide, but kind of harkens back to what we saw with carotids. But when you lose a triphasic waveform, that's actually concerning. More monophasic waveforms indicate more significant stenosis. Spectral broadening, I mentioned Dr. Stenosis before, using that to discover worsening carotid flows, and that principle holds true in the peripheral arterial circulation as well. Increasing peak systolic velocities is also suggestive as well, and the ratio can sometimes play a part in more significant disease. And shown here are different criteria. Usually we look at 2.5 to 3.5 or greater ratios as significance. And of course, we do not ignore wall morphology as well. Okay. When it comes to doing angiography in the CT and MRI world, we actually use a process called bolus angiography. And so what happens is we inject a bolus, wait some time, and then image. And if we time our imaging correctly, we'll actually be able to capture first pass arterial phase through the vasculature and be able to get an arteriogram uncontaminated by the venous structures. In the MRI world, we usually follow up with venous imaging so that we get a whole complete picture as well. But the principle that is seen with MRI also holds true with CT. Whether or not you do fluoroscopic triggering, waiting to see when it is about to highlight your vessel of interest using repeated sampling of the inflow, or do a time bolus where you do a test bolus first and then figure out based on timing when you should trigger imaging. We employ both as methodologies in the CT and MRI. MRI we tend to do more fluoroscopic. CT tends to employ both. MRI, I'm happy to say that based on new consensus between the American College of Radiology and National Kidney Foundation, there's been a little more leeway in terms of using gadolinium in renal patients, including dialysis patients, because it's felt that the benefits outweigh the risk. And not to mention the newer gadolinium agents, the newer generation macrocyclic ionic compounds have much less risk of depositing in the body and increasing the risk of nephrogenic systemic fibrosis. If the kidney function is still concerned, and iodine and gadolinium are both not ideal, there is the option of ferromoxetol, ferraheme, also called ferraheme, but ferromoxetol is an iron nanoparticle that can be used in MRI for vascular imaging. This is an agent that will stay in an intravascular compartment and allow us to see the arteries using MRI. Shown here is an example of an MRI, and shown on the left is an arteriogram. You can see only arterial structures are highlighted. You can see the aorta and the arch vessels as well as the visceral vessels all nicely highlighted, and only the trace beginnings of the portal veins and the IVC beginning to be highlighted. So this is the arterial first pass arterial phase imaging on MRI. MRI on the right. Above is the raw data, the coronal images we acquire. On the bottom is a maximal intensity projection, kind of a virtual angiogram, if you will, that we can reconstruct using these data. On the left hand of the screen. On the right hand of the screen is delayed imaging, where we can see all the venous structures now highlighted as in turn. Okay. In terms of diagnostic performance, ABI is extremely sensitive and specific, as well as CT and MRA. Examination is only so-so. Remember I mentioned trivia-wise, the posterior tibial artery. If you lose the pulse, that's more specific, but that is well known. If you suspect PAD, ABI is a good screen tool, especially in symptomatic patients with claudication or patients who have questionable claudication syndromes. And then following up with CTA or MRA is helpful. Every now and then, especially in patients who've had procedures, such as those who've had femoral approaches for coronary angiograms or had femoral access by the vascular surgeons, may end up with pseudoaneurysms. And shown here is the so-called Pepsi Cola sign. I, again, have no financial interest. I have no conflicts of interest with any kind of anything with Pepsi, etc. But there's a swirling pattern, and because there's a swirling pattern in the pseudoaneurysm due to usually a narrow neck, that creates this kind of red and blue appearance that's classic to and fro flow in the pseudoaneurysm. But when this is seen, you should get your vascular surgeon involved, and maybe if it's small enough, they can do compression to try to force it to clot off and close. But if the neck's wide or there's pseudoaneurysms large enough, you may have to get request they do a thrombin injection, and it's very dramatic to see. They go in with a big catheter, inject a small amount of thrombin under live ultrasound imaging, and everything clots off. They have to make sure, of course, they don't overdo it and cause it to propagate into the artery proper. Every now and then, because of the tendons inserting into the knee, this can lead to popliteal entrapment syndrome because it can impair the popliteal artery. And there is an entire classification system that is present regarding the tendons and muscles. And I leave this here for your reference. I won't go into great detail about this. Moving on from the arteries to the veins. Veins are a very frequent reason for requesting vascular imaging. Obviously, I'll be covering certain entities such as venous thrombosis, but then there's also the weird and wonderful as well. With that, this requires some knowledge about venous extremity anatomy. And one thing I will discuss is that once you get into the more distal limbs, and I'm talking about the forearms and the calves, for every vessel, artery vessel that you're used to seeing, like if there's an anterior tibial artery, posterior tibial artery, and peroneal artery, there's actually usually two veins, two corresponding veins that flank it. So whenever you do vascular imaging and are doing venous assessment, you should be used to seeing two veins flanking the artery. That's why if you wait too late on an arteriogram and the veins begin filling up, this can result in the what we call venous contamination, make it very, very difficult to assess arteries in the more distal limbs. So timing is important in that situation. In addition to venous thrombosis, there's also the entity of chronic venous insufficiency. So you may notice this in patients who have edema that can't be explained otherwise by some organ dysfunction, such as the heart failure or liver dysfunction or kidney dysfunction, and sometimes venous insufficiency can result. I see we have quite a few questions coming through. I will try to address them in turn and wrap this up, but I'm almost done, and I'll try to move a little more quickly. But chronic venous insufficiency can be concerning, especially in patients who have either severe cosmetic concerns, or if it starts causing issues with wound healing, and in the most extreme cases, venous return. You can actually have limb circulation and ischemia compromise due to chronic venous insufficiency in the more extreme cases. There's also arterial venous malformations. These tend to be more congenital. The biggest ones are Parkes-Weber syndrome, which is more an arterial venous malformation issue. And then there's also Klippel-Trenaunay syndrome, which is both an arterial venous and lymphatic malformation issue. So that's the way to differentiate these two congenital abnormality. With venous insufficiency, there's the entire classification scheme, and this can come up in cardiovascular boards, but one has to organize the severity of CVI based on clinical, etiologic, and anatomic and pathophysiologic characteristics. With venous thrombosis, this is a concern because this is a segue to possible PEs, pulmonary embolisms. But on venous ultrasound imaging, there's concern about phasic loss because venous flow is usually respirophasic and pulsatile. You can also do maneuvers to try to see if you can augment venous blood flow, such as muscle contraction, or impair venous return using Valsalva. But those maneuvers can help you figure out venous signals and differentiate venous thrombosis versus arterial issues. On MRA, you can do what's called TI-600s or TI-1000s, but the bottom line is these are contrast-enhanced images for picking out venous thrombosis. And thrombosis can actually evolve over time on MRI because of the transition in iron content. This will actually lead to initial bright T2 and T1 weighted characteristics because of the iron cation shortening magnetic properties. But then as it ages over time, usually by over 6 weeks of age, it results in a very dark signal. I mentioned Klippel-Trenaunay syndrome, which is more an arterial venous lymphatic issue. And I also mentioned Parkes-Weber syndrome. But if you see all these different pockets and malformations, that should prompt a consideration of these entities as well. Let me brush through. Vascular anatomy, usually with the visceral anatomy, there's a celiac axis, SMA and IMA. Usually we pay more attention to the celiac arteries and SMA, less so the IMA, and of course two renal arteries. I won't go through these characteristics much. There are entities such as the celiac compression syndrome or median arcuate ligament syndrome. Usually presents as a fish-hook appearance in the celiac arteries, not to be confused with actual atherosclerotic stenosis. Usually there are maneuvers you can do to see if there's changes, because when patients inspire, that actually causes exacerbation of the celiac artery circulation, and that can be picked up on ultrasound and on Cine and phase contrast MRI as well. There are visceral artery aneurysms, and these are catastrophic if they are if they're left undetected, because they can rupture and cause problems. Renal arteries, you can have different variants as well. You can have what's called accessory arteries, where they go to the hilum, or you could have aberrant arteries that go to other parts of the arteries as well. There are arterial characteristics that I won't go into as much detail, but there's also renal artery perfusion imaging that can be done by MRI and other techniques to determine if there's significant disease. There's also venous pathology, such as pelvic congestion syndrome, compressive syndrome, such as nutcracker and Peytherner, and portal venous obstruction. Shown here is pelvic congestion syndrome, because the gonadal veins tend to pass through the left renal vein, trying to get back to the IVC, which can be associated with nutcracker syndrome, where the SMA and infrarenal aorta can compress and pinch off the left renal vein, trying to get back to the IVC. There's May-Turner syndrome, where if you have the May-Turner anatomy, where the right iliac artery can compress the left iliac vein against the vertebral spine, you can end up with a syndrome when there's corresponding edema and venous thrombosis that develop with that. Portal hypertension, I won't go into this in great detail, other than to say that we look at flow patterns on ultrasound. So hepatofugal going away from the liver back into the IVC is suggestive of more hepatic venous flow, whereas hepatopedal vein, circulation with the portal veins tend to be the nature of portal veins. That gets reversed though in portal hypertension. And last but not least, the lymphatics are actually getting increasing importance as well. It turns out lymphatics are important in terms of blood volume return, and it's being increasingly recognized. There are different modalities such as scintigraphy, indocyanine and green, lymphography that can be used, contrast MRI, where you inject a lymph node and try to pick up lymphatic circulation, is also becoming increasing importance, especially in patients like the ones Dr. Valeria Duarte has described last week with Fontan circulation, et cetera. And it's actually being recognized that its presence in different conditions, such as the coronary disease, valvulopathies, it actually increases in certain valve conditions, as is endocarditis, and is present, gets involved in atherosclerosis as well. But with that, I'd like to summarize by concluding that imaging assessment of vascular disorders requires a fair amount of knowledge of regional vascular anatomy and pathophysiology, that the vascular laboratory remains a first-line modality for assessment of many vascular disorders, that CTA and MRI offers highly sensitive and specific exams of the vascular diseases, and that lymphatic imaging is a growing area of research for cardiovascular diseases. With that, I'm going to take a look at the different questions that have come through, and I see that there have been quite a few. Let's start off with, in case of severe stenosis or occlusion with the compensatory circulation mechanisms, can this collateral circulation influence assessment of the severity of plaque distals or proximal to the first stenosis on the same artery or in one of its branches? The answer is yes, because what typically happens is that you're still able to pick up pick up more immediate distal to the stenosis, the increased velocity flow. And you'll also be able to pick up also the elevated diastolic flow if there's significant post-stenotic dilatation as well. But collaterals, but once you go more distal and there's a significant reconstitution of flow, then it becomes a little harder to detect. But just more immediately distal to the blockages, you can still pick up things. Does the presence of tortuosity in an organ heighten the likelihood of fibromuscular dysplasia, FMD? If yes, should it motivate an FMD screening be performed in other organs? So tortuosity is a little more difficult to discuss because tortuosity is kind of a defense mechanism of the body in older individuals against that loss of elasticity, as I mentioned. It's trying to compensate for the increased pressure load on the distal organs. So that's a bit separate process from FMD, if you will. So I'm not sure there's any real I don't think there's any real concern about teasing out tortuosity versus FMD in older individuals because it tends to, in older individuals, to be more likely due to tortuosity issues, whereas FMD tends to be more a concern in younger individuals because it tends to be more of a congenital and inherited issue. Are there cases in which we need to add a dynamic step before imaging to diagnose a vascular kinking or compression by a muscle? That's an excellent question. I would have to say that depends on the patient's anatomy. So if the patient happens to have an anatomy in a particular regions, I mentioned popliteal entrapment, I mentioned the stylohyaloid compression in the carotids. It really depends on the patient's anatomy. Anterior scalene arteries for anterior scalene muscles in the neck, for example, can also pinch off things, and some patients have to go for a resection of that to help. So it really depends on the patient's unique anatomy, and if it's suspected, then having a good vascular expert work with the patient and doing appropriate diagnostics with an experienced lab is helpful. But it really depends on the patient. Are there organs other than the heart for which we can currently use contrast ultrasound imaging? Now, that's an interesting question. So there was actually work done by Dr. Feinstein I believe it was Dr. Feinstein et al. Up in Rush up in Chicago, where they were actually using carotid ultrasound contrast to look for microcirculation, vasovasorum imaging in plaques in the carotids, and that was considered a poor prognostic sign of plaque stability, regarding plaque stability. That is an area that's still open for research. I believe some people are still considering that. It kind of makes its way in different ways in other modalities in assessing plaque structure. But there is a consideration about using ultrasound contrast, but that still remains well in the research realm, not in the clinical realm. Is there a vascular imaging that requires the suspension of a vasodilator drug or with a vascular tropism? That's a good question. Not that I'm particularly aware of. I don't believe there's any, other than the brachial artery reactivity testing I mentioned before, where they do use nitro to try to provoke a response. I don't believe there's any other established protocol, consistent protocol where vasodilator testing has been established for use for microcirculation assessment and the peripheral vasculature. But that is another avenue for potential research down the road. And that was looked into when I did work with a colleague looking at calf perfusion here at Methodist. Any other questions? I don't see any. But thank you all for being with us today, and it was a pleasure to talk to you about assessing the peripheral vasculature and all the different pathophysiologies that exist and how we may assess it. With that, I thank you for your time, and we hope to see you again next week.